We'll move on to Dr. Chitra Ramamurthy. She will talk to us on capsule stabilizing rings, hooks and phaco techniques. She is a very prolific phaco surgeon, and we would like to hear the details from you, madam. Over to you.
Good afternoon, one and all of you, and my very special thanks to Dr. Meenu Mathan for remembering me for his course. My due in the next few minutes is to talk to you all about subluxation in different cases. So when the lens is displaced from its normal position but remains in the pupillary area, it's called subluxated lenses. And when it is completely displaced from the pupillary area, it could be anterior dislocation or a posterior dislocation. Again, it's very important to know what is the extent of zonular weakness before you start, and based on KSOS, it's divided from mild, moderate, severe and very advanced zonular weakness. But one point to remember is that what you actually see on the slit lamp may not correlate exactly with what is on the table, so on the surgical table. So you should be prepared for a greater zonular weakness than you saw. It is also important for us to know that what is the kind of zonular weakness. Is it a progressive disease, a progressive zonulopathy like a pseudo-exfoliation of Marfan's, which has to be tackled differently as against a traumatic or an iatrogenic zonular weakness. Again, if it is dislocated, it's lensectomy either on the limbal or the pars plana route, and these are those AC IOLs, iris clip and SF IOLs. But if it is just a subluxation and you're going to conserve the capsule bag, that is when you're going to use the CTR, the iris or the capsule retractors or the CTS. The most important thing is how do you get your rhexis. It needs to be a centered rhexis. There's a lack of zonular traction. So it's very difficult to size the rhexis. So you need to aim for a little smaller rhexis. You should inject cohesive viscoelastic to flatten the dome of the anterior capsule. You could actually have to initiate the rhexis from the area where the zonules are intact towards the area of zonular weakness. And you could use counter traction with capsule retractors. Now, how do you stabilize the capsular bag? You could use iris hooks, capsule hooks, CTRs or Ahmed segments. And I'm going to be showing you videos as to how I used each of these in different moments. Now this appeared to be a normal cataract. There was no phacodonosis. I've injected the dye. But the minute I start my rhexis, that tactile feel is not there. I know that the bag is loose. So I decide that I'm going to make it a small rhexis, and I gradually, with greater confidence, enlarge it to a fair size. But I know that I have to place capsule hooks, not iris hooks, to stabilize the capsular bag. It might be appearing like an overkill at this time. The nucleus is rotating well. I'm able to chop the nuclear fragments, and I'm actually chop it. Everything, the AC is stable, but then look at that small area superiorly. That small area of zonular weakness, I immediately place a capsular hook. But the fact that there is followability and ability to rotate says that there is no vitreous disturbance as yet. But then I realized that the bag is really weak, so it's the time to place the CTR. And I use my second hook through the side port to tuck the CTR in, because with the nuclear fragment, you might inadvertently place the CTR in the angle and not within the bag. You need to circularize and stabilize and give it the equatorial support. I keep the phaco probe in the pupillary area, get the pieces towards, bring down my phaco parameters when it comes to the last fragment. And then, without removing the cortex, I place the IOL inside the bag like an IOL scaffold, because I want that IOL to stretch the capsular bag. And then, yes, it is a little more difficult with the IOL and the CTR to tease out the cortex, but it has to be done tangentially, but you can get away with it. Now, this was the second case where there's more than 4 clock hours of dialysis. Again, you need to get a nice round rhexis. That's an absolute mandate. You need to do a good hydro, because you want your nucleus to be mobile, because phaco manipulations with a not so mobile nucleus would increase the stress on the zonules. Then I place capsular hooks in that area alone, do a stop and chop, finish with the removal of the nuclear fragment. And the plan of action here is to place a sutured Sionis ring. I pass it in a clockwise direction and position the eyelet in the area of maximum weakness. And then I remove the hooks, place the intraocular lens. This is a very old video, and here a triangular flap is created in the sclera, and then the railroading technique is done in the usual manner, so that I get both the sutures under the triangular flap, suture it, and thus ensure that the bag is attached to the scleral wall. Now this was a case of an iris and a lens coloboma. So this, of course, it means that the zonules could be weak there. The zonules in the other part could actually be fairly strong. I've injected a cohesive viscoelastic in that area of weakness to push back the vitreous so that it doesn't come forward. I initiate my rhexis such that the rhexis is less towards the area of the zonular weakness and more away, but ensure it is to be a nice round rhexis. Now that is an absolute critical factor which you need to address when you're doing phaco emulsification in a subluxated cataract. So after completing my rhexis, I definitely do a hydro, but again, the only challenge here, there could be a fluid misdirection, wherein during a hydro or during a phaco emulsification, fluid can go in behind the lens and can make it a very shallow anterior chamber and a lot of pressure in the eye. However, that did not happen, so you need to keep injecting viscoelastic in that area to push the vitreous away. Everything seems to be going well, so I go ahead and even try to remove the cortex. But a point comes wherein there is a doubt. I realize that it's time I place my CTR at this point of time. Many a surgeon would want to place a CTR right in the beginning. That would actually have a preventive role in causing fluid misdirection. However, that was done and the lens was placed. This is another kind of a coloboma. Maybe an overkill here, but I have made a Hoffman's pocket at this point of time. And now I'm going to make a nice round rhexis away from the area of probable zonular weakness in that area of coloboma. Again, herein you could place your CTR right now, but I still go ahead and do a hydro. It's a very soft nucleus, so with IA, I'm able to aspirate all the lens matter. And now I place my CTR. Now, when you place your CTR, you should ensure that the eyelets do not overlie the area of zonular weakness, but rotate it such that the long arm comes to lie in the area. Now, probably I could have placed my lens there because I know the other areas of the zonules are fine, but then you need to remember that this area of weakness could cause an asymmetric back contracture because of which a CTS was placed. This was a case of a very significant zonular weakness. So again, a Hoffman's pocket is being created, as you can see here. The extent of zonular weakness is very significant. I'm injecting viscoelastic to push back any probable vitreous, flatten the dome of the anterior lens surface, and initiating a rhexis in this extent of subluxation is truly a difficult fact. You have to keep pulling the rhexis towards the center while initiating rhexis. Capsule hooks are placed. Again, it's a very soft cataract, so IA is used to aspirate all the lens matter. You need to then, after you have removed all the lens matter, you need to inject viscoelastic. Never over distend the bag when you are dealing with a subluxated cataract. A second hook is being placed here, and now I'm going to place the CTR into the capsular bag, which will circularize it, but that does not suffice because the extent of zonular weakness is too much. You have to place a CTS, a single CTS or a double CTS, and now I decide to remove one of the capsule hook. The CTR is there in place. And now I'm going to pass a suture through the eyelet of the CTS, inject viscoelastic to push back the posterior capsule, and position the CTS in that area of maximal zonular dialysis, and again do the railroading technique, which is a skill which needs to be acquired, and then complete the case. Now, when there is a very significant dialysis, a severe pseudo-exfoliation, you need to be able to assess that doing phacoemulsification will be very hazardous. So the plan of action from the very beginning was to do SICS. The plan is also to use the iris clip lens. So a 3 o'clock and a 9 o'clock incisions are made, through which I'm going to tuck in the haptic in the iris. So I'm just trying to confirm what is the extent of dialysis and use my lens scoop and get the entire nucleus along with the capsular bag out. The pupil is quite small. I need not inject a pilocarpine in this case, but you need to do a shallow anterior vitrectomy to ensure that if the vitreous is cut. And I believe if the vitreous is well cut, you need not even do a PI in these cases. And I'm not going to actually go in and show the details of how the iris clip is placed. It's done, and it should be something which you all know. An extreme situation, a very pseudo exfoliation, progressive in nature, and if you just place a CTR in your cataract surgery, you could have the whole thing subluxating into the vitreous, which is when you need to do a glued IOL or a SF IOL. So essentially, the whole route of how you're going to manage subluxation depends on the extent of subluxation which you visualize, a CTR, using capsular hooks or iris hooks, or going on to a CTS, or deciding to do a glued IOL or iris clip IOL. Thank you very much.
Thank you very much, madam. This was a master class in itself. So this was a very extensive description on how to do a perfect phaco in all these kind of different situations. I don't have anything to add on to this. Any questions to her? I think we'll take it at the end.